On behalf of Intas Pharmaceutical, I, Dr. Mithilesh Nayak, welcome you all to this webinar. In these challenging times of COVID-19, by staying at home and following social distancing norm, we can indirectly fighting against the non-communicable disease like COVID-19. But at the same time, by using advanced technological platforms, we can continue our fight against the endocrine disorders by upgrading our knowledge from emerging evidence. And by keeping this objective in mind, we have designed a webinar series, the practice call in endocrinology. And for us, it is privileged to have with us our post director for the webinar series, Professor Subhankar Chaudhary sir. Dr. Professor Subhankar Chaudhary sir is the professor and head of the Department of Endocrinology, Institute of Postgraduate Medical Education and Research, and SSKM Hospital, Kolkata. He is Editor-in-Chief, Indian Journal of Endocrinology and Metabolism. He is past President of Endocrinology Society of India and past Secretary, Research Society for Study of Diabetes in India. He is a member Subject Expert Committee, CDSC of Government of India. He is also a founder patron South Asian Federation of Endocrinology Societies, and he has more than 170 publications in various national and international journals. So with this, I welcome Professor Subhankar Chaudhary sir on this digital podium. So I request Dr. Subhankar sir to guide us further and tell us the more ideas with regard to our program. So over to you, sir.
Very good evening and a warm welcome to all of you from all across the country. It's though we feel at some point that physical meetings are better, but this way you can connect more easily to more number of people. The digital platform is actually becoming quite a hit, and in course of time, amongst the various other things that are changing our lives, possibly the way we'll conduct meetings will also change possibly in the days to come. The digital platform probably will be here to stay. So what we planned is to give an hour's time to our physician colleagues all across the country, some words of wisdom and share practical knowledge from the endocrinology field. And we have been promised support by eminent people in the realm of endocrinology across the country. So we will cover various interesting and topics that are of interest and of use to the practicing physician, not discuss theory here. Mostly it's practice related, and we'll cover various areas like bone metabolism, calcium, phosphate issues. Thyroid, of course, is a common issue. Reproduction, either male or female. Diabetes will also be part of our package. We'll have obesity, we'll have lipid disorders. We'll also touch upon interesting other endocrine problems, which may not be that common, but must be vexing to the practicing physician, for example, pituitary problems or adrenal problems and so on. So with these, let us get into today's topic, which is to do with bone health and to do with osteoporosis. And we are really fortunate to have two of the doyens in this area this evening. We'll first have Professor Sanjay Vadada, who, as you all know, is a professor of endocrinology in the Department of Endocrinology at PGI MER Chandigarh. And he is someone who is hugely interested, connected with bone mineral metabolism disorders. He has been actually a past secretary of the Indian Society for Bone Mineral Research. He has a huge number of publications, many of them in this area of bone mineral metabolism. He's got more than 250 publications, and it will really be sort of whatever we hear is something like hearing from the horse's mouth. We will also have later in the evening, after him, we'll have another doyen. We'll have Professor Sushil Gupta, who is Professor of Endocrinology at the very prestigious Sanjay Gandhi Postgraduate Institute at Lucknow. He is also intimately associated in this area of bone mineral metabolism. He has also contributed immensely in the form of various, almost 100 original articles, and is also the current vice president of the Indian Society for Bone Mineral Research. So if we come back to the topic of osteoporosis, as we are talking about a pandemic of COVID, infective or infectious pandemic, we also talk about the pandemic of diabetes, but there is also the pandemic, the silent pandemic of osteoporosis. And you get to know about it when the bone fractures. It's clearly the orthopedics, they are our great colleagues. They are doing a great job fixing those bones and getting people to walk again back to their normal life. But I think we need much more than that. We need to prevent those fractures to the extent possible. And after a first fracture, we need to make sure, because it's very common knowledge that after you're fractured once, your chances of getting a second fracture are much higher. For example, if you have a first vertebral fracture, then you are at a 5 times higher risk of getting another vertebral fracture. And in fact, within a year, you have at least possibly about 20% chance of getting another fracture. And not only that, we also know that the fracture incidence and the prevalence are very high. In fact, if you take the number of fractures, the osteoporotic fractures, they would exceed the number of strokes, the number of myocardial infarction, the number of invasive breast cancers that we see in a year. So in a way, that is a really important area because it has got economic considerations because of compromise of your life pattern, especially if you had a hip fracture and if you have not healed properly, you cannot go back to normal work. And it's very important to note that if someone sustains a hip fracture today, he or she has at least about a 30% risk if it's a she, and if it's a he, about 15-20% risk of dying in the coming 1 year after sustaining a hip fracture. Not always, not directly related to the hip fracture, but to various other issues. So it's very important that we as physicians, especially endocrinologists, we take the fight against osteoporosis, the fight against fractures forward, while keeping our, of course, showing great faith and respect to our orthopedic colleagues. I think there's a lot of work for us to cover. And India, as one of the Asian countries, will become one of the commonest countries to show also the prevalence of osteoporotic fractures. Just like we have high numbers of diabetes, high numbers of myocardial infarction, we also have high numbers of osteoporotic fractures, many of which we do not recognize. So I think we should now get on to the subject proper, and I'm very happy to have with us and invite Professor Sanjay Vadada to talk us on basic issues, lifestyle factors, and with special focus on calcium and vitamin D in relation to osteoporosis and in relation to prevention of fractures. Over to Sanjay.
Share screen. Hello.
Yes, good evening. Can you share your slides? Yeah, can you share your slides?
Yeah, I am sharing my slide only. It is not visible.
Not yet to me.
Just a minute. Grant support system. Sham is asking for permission remotely control your desktop.
Yes,
Grant permission.
Good to see Sanjay. You seem to have grown younger. It's good to see you.
Thank you, sir, for the kind words.
Yeah.
Just.
Yeah. Now it's come.
It is slides have come now.
Yeah. So you have to go to slideshow now.
Yeah. Yes.
And We others will be muting our mics.
Yeah. Yeah. So, very good evening to all of you. And Subhankar Chaudhary sir, thank you very much for the kind and elaborate introduction of me. And the topic for this today's talk is given to me is role of lifestyle with focus on calcium and vitamin D. So when we talk about the calcium and vitamin D in the management of bone health, you can say it is similarly like when you are talking about diabetes and the diet or the exercise. So it is, we can say similarly like when we are making a building, until unless you will not make the ground floor, you will not going to make a first to the second floor. Similarly here is the importance of calcium and vitamin D in the management of bone health, whether it is osteomalacia, whether it is osteoporosis, whether it is peak bone mass, everything. So calcium and vitamin D are very, very important and the basic for the good bone health. So this title, when given to me, I thought lifestyle. What is the meaning of the lifestyle? The lifestyle is the way in which a person lives. What is that is lifestyle? So person lives meaning by that where is he living, what he is eating, what he is wearing, and so many things, who are in surroundings, how much is the sunlight, so many things are there in the lifestyle. But I am asked to specially speak about the calcium and vitamin D. So I am going to cover these two topics. If time permits, we can talk something about the fall prevention as well. So coming to the first, calcium in the bone, we know that calcium is primary constituent of the bone and it is deposited as hydroxyapatite crystal with phosphate into the bone, and that is actually called the bone mineralization, or the we can call it is biomineralization. So calcium plays a very, very important role in the biomineralization. If calcium deficiency is there, the mineralization will be affected and then can cause lot of problems or the diseases like where there is rickets, osteomalacia, inadequate achievement of peak bone mass, and then finally it culminates into the osteoporosis or these fractures. So calcium mainly comes from the source of calcium is the diet, and the calcium intake per day is approximately 1 gram per day is required for the childhood and adolescence to achieve the peak bone mass. For the listener, the peak bone mass is the bone mass which is achieved, and that is the maximum, and that is achieved usually in the second and third decade of the life. But here is some issue with the peak bone mass among Indians. The whatever Indian studies are there, they say that peak bone mass is achieved not in the second and third decade, rather that it is achieved in the third or the fourth decade. So it's an interesting question. Here we are different from the Western population. So adequate calcium intake in adulthood as well as elderly is help in the childhood is help in the to achieve the peak bone mass, while in case of older people it helps in retaining the bone mass or preventing the rise in the PTH along with the vitamin D to inhibit the bone resorption, as well as it helps in the bone deposition as well. So low calcium in the diet leads to the low bone mineral density in the childhood as a does not achieve the peak bone mass, and in elderly patient or the older people it leads to the increases for the osteoporosis. So coming to the diet, that what are the various source of the calcium in the diet. So in this particular slide there the three columns are there. The extreme left, that is calcium content of the dietary products, dairy products and the poultry, that is per milligram or the 100 gram. So you can see that the maximum number of calcium or maximum amount of calcium is present in the milk or the skimmed milk. So meaning by that 100 gram of the skimmed milk contains approximately 1400 milligram of the calcium. The cheese is good source. Approximately 80 gram of 100 gram of cheese contains the 790 milligram of the calcium, followed by various other milk products like whole buffalo milk, like skimmed milk, doodh, anda. Also, egg also contains approximately 60 milligram of the calcium. So these are the various dietary constituents that will help us to know that how much amount of calcium we are consuming through the dairy and the poultry products. On the upper right side corner, there is a slide which is showing that calcium content of the grains. So it is showing the ragi, which has a maximum amount of calcium, that is 344 milligram of calcium per 100 gram of ragi grain. But unfortunately, ragi grain is not widely consumed in the most of the part of our country, except I believe till I was searching for the ragi in detail few years ago, I was not aware that ragi is available freely in the northern part of the country, but it is well known in the southern part of the country where the ragi is consumed in various forms. So ragi is good source, but remaining other grains are not very good source of calcium, and that you can say this among those are, one is that rajma contains enough amount of calcium, that is, and as well the soya bean, and some other pulses also contain, but the amount of calcium these pulses are not really very good. Then coming to the vegetables, certain vegetables are also good source of the calcium, and among them, especially the leafy vegetables having the good source of calcium, but simultaneously they also have the phytates, the absorption is not that good. So these are the, this slide is particularly telling the what are the various sources of the calcium in the dairy products, in the grains, as well as in the vegetables. Now coming to the calcium, that calcium is available in the diet, and we know in our practice we do prescribe the calcium. So now question comes is that which calcium is better? What should be the ideal source of calcium for a for consumption? So preferred is the dietary source of calcium, and there are many reasons that why we should prefer the dietary calcium as the primary source of calcium consumption. One is that dairy products are used by most of the people, and that's why you can achieve enough amount of calcium of your requirement in your day-to-day basis. Second, the absorption of calcium is better with the dairy products as or the dietary products as compared to the other sources. The third important reason is that the dairy products, in addition to the calcium, they provide many other nutrients like potassium, magnesium, zinc, iron, riboflavin, folate, vitamin A, and vitamin D if the milk is fortified. So you can say that dairy products are not only the good source of calcium, but those are also good source of various minerals and the vitamins. Those are very, very important and playing an important role in the bone mineralization or maintaining the bone mineral density. The problem here, one thing we have to keep in mind is that absorption calcium is in diet is affected by the phytates. And in India, especially, the phytate is very high in the diet because most of the people are using the staple diet is the wheat, and the, you can say grain is the staple diet, and the grain is even enough amount of phytates. That's why it inhibits the absorption of the calcium, because calcium and phytate binds in the gut, and that is excreted in the stool, and that is absorption is inhibited. So that is one of the issue, but still this enough amount of calcium is there in the diet and can be absorbed. Another important issue is lactose intolerance, an issue especially in the elderly people. Though this is not a very common complaint, but if you ask the patient and they come with the special complaint that they are having lot of GI intolerance in form of indigestion, and we further poke into the history, they'll tell that when it is more common. So many of people come out with the saying that when they are using the milk, there is a problem and they are having this problem. So there is indirect evidence that these patients are having the lactose intolerance, and the lactose intolerance is there, then that calcium is given by the diet will be not absorbed, or and that can cause harm. So here is the important point: if you are using the dairy product, especially the milk, not the curd but the milk, if you are using, and the patient is having the symptom of lactose intolerance, and that particular person, the milk may not should not be used as a good source of the calcium, because it will not allow you to absorb not only the calcium, but this lactose intolerance will cause malnutrition, and it will inhibit the absorption of other micro and macronutrients. So this should be keep in mind. And there's now a lot of literature is available on the lactose intolerance from our country, and from our institute, a few publications on that lactose intolerance and the post-menopausal osteoporosis, and we found high percentage of people are having the lactose intolerance. Now coming to the what is the ICMR dietary calcium daily recommendation is there. So for the up to 1 year of age, that is 500 milligram per day, and the children from 1 to 9 years 600 to 800 milligram, and for 10 to 15 years it is 800 milligram, and from 16 to 18 years is 800 milligram per day. But I believe it should be high, and maybe it is little older publication, the recommended is should be increased for the to achieve the better peak bone mass. For the men and women it is again 600 to 800 milligram per day, and for the pregnant ladies and the lactating mother, it should be 1200 milligram per day. So these are the recommendation for the daily allowance, but I believe this is not the recommendation when you are talking about the osteoporosis. In that situation or in the perimenopausal period, the diet, it should be at least 1000 to 1200 milligram of calcium should be given or should be taken to maintain that good peak bone mass, as well as to keep in check of the PTH. Though we know that PTH is mainly checked by the vitamin D, but the various studies are there. Those are telling that calcium plays an equally important role to check on the PTH level. So let's see the what is the worldwide situation of the dietary calcium intake. So you can see here that on the lower left side, you can see that people areas which is less than 400 milligram of calcium intake are in the red, and this 400 to 500 milligram in the dark red color. And you can see that India is having the dark red color, meaning by that our average calcium intake is varies from 400 to 500 milligram. So meaning by that our calcium intake in diet is less as compared to the recommended dose is at least from 800 to 1000 milligram per day. And a person is having osteoporosis, then it will can go up to the 1000 to 1200 milligram per day. So to understand that, to learn that what is the calcium content in the Chandigarh region, so we did a small study under the heading of the Chandigarh Urban Bone Epidemiological Study. So where what we did is that in the large study of 1500 patients, every fifth patient was assessed for their dietary content of the calcium, and the method was the 7 days recall method. And by the 7 days recall method, approximately 300 patients were studied, and what we found is that dietary calcium intake was 391 in the 391 total as a in the male and female as a mean, while in case of male it was little higher, 432, while in case of women it is 350. So now it is important is that in the India and the I believe that Haryana and Punjab are well known for the good amount of milk and milk product consumption. In spite of that, this population is having just average vitamin D, average calcium content in their diet is 391 or approximately 400 milligram, meaning by that we are rest of the country might be consuming even lesser than that. So the requirement or the recommendation is that we need to increase the calcium content in our diet, or if it is not sufficient from diet, you can take the supplementation. Another part of the cube study is that though that we recommend the calcium in our laboratory, that upper limit is 8.5, limit is 8.5 to 10.2 milligram. But what we found in that our study is that upper limit is 9.2, 9.1, or in the postmenopausal period, that is the 8.7 to 9.3 milligram. So though we are using all Western data that what it should be the calcium cutoff for our population, but in the from cube study, the values are little different. And similarly with the vitamin D. So this study is very recent. It was done in 2019, 17 to 2019, and still a huge number of population is vitamin D deficient. So the calcium and vitamin D is probably not in the attention of the most of the physicians, or maybe the at least in general population, that they are not consuming enough amount of calcium or not supplemented with enough amount of vitamin D. So now needs for the calcium plus supplements, always best to get RD of calcium from the diet, as I mentioned already. Calcium supplementation only when dietary calcium intake falls short of the RDA. because calcium supplements in diet will provide so many other nutrients. So preferably it should be from the diet. Choice of calcium, very frequently asked question is that what should be the calcium we should take. So there is certain questions I framed for the audience is that which calcium. It is very commonly asked question that which calcium an individual should take. From the scientific point of view, all calcium are same. Whatever you want to take, you can take. When to take calcium, that is very frequently asked question. Should we take after meal? Should we take empty stomach? Should we take the bedtime? Should we take after lunch? So calcium carbonate, if a person is taking, it should be taken with meal, because calcium carbonate requires acidic pH for its absorption. While other calcium can be taken at any time of the day, and calcium citrate maleate can be taken even the without meal also. How much calcium? As I already mentioned, what will the maximum dose in the single time? So preferred is 500 milligram, because the lower the dose, better is the absorption. So though recommended is 1000 milligram, but if a person is taking 1000 milligram at a time, then absorption will be not that good, because for the calcium absorption there is a receptor or the protein that is called cal binding is there. So if it is saturated by taking high amount of calcium at a time, it will be not absorbed. The safer upper limit is recommended is somewhere 2500 milligram per day. If it is more than that is taken, it can cause hypercalciuria and patient may present with the nephrocalcinosis or the renal stone disease. Is there any way to reduce the calcium requirement? Yes, the calcium requirement can be reduced by or can be optimized by the taking low salt, because there is calcium in salt is excreted urine in the urine. If the high sodium is taken, the calcium is also excreted with in the urine with sodium. So if you restrict the salt, then you can reduce your calcium requirement as well. So then now question is that these are the various preparations of calcium that are available, like carbonate, phosphate, citrate, acetate, lactate, gluconate, orotate, and many more are there actually. But one glimpse on this bioavailability. So the calcium carbonate has a bioavailability which is most commonly prescribed calcium is 22%. The calcium citrate has a viability of good, that is 42%. And the calcium orotate has a very good bioavailability, that is 95%. So you can see the if bioavailability is more, in that case your calcium, elemental calcium you may not be taking is not that high. So that you know that when the calcium carbonate is usually prescribed, the elemental calcium content is somewhere 600 milligram or 500 milligram. While when we prescribe citrate, it is usually 400 milligram. When we prescribe orotate or the other calciums, then there is dose is somewhere around 200 milligram per tablet, because the absorption is good and the bioavailability is good. So you can choose the calcium on the basis of what suits the patient. We know that many patients are not tolerating all the type of calcium, and they have a problem with some or other calcium. Then in that case, you have to rotate the calcium or the change the calcium for the patient in related GI intolerance or the constipation. Now, very frequently asked question is safe to prescribe calcium in presence of renal stone disease? So if you know any cause of renal stone disease, better to take care of that. But if the calcium deficiency is in the diet or the vitamin D deficiency in the diet, it can also predispose us for the renal stone disease, because the vitamin D and calcium are the important regulators of the PTH. If the calcium and vitamin D are deficient, that will not able to suppress or they keep check on the PTH, and in that case PTH will be high in deficiency of calcium and vitamin D. So more PTH, more calcium absorption or resorption from the bone, and more hypercalciuria, and that will predispose for the renal stone disease. So what is the choice of calcium in presence of the renal stone disease? The preferred choice is calcium citrate maleate, because we know that citrate inhibits the deposition of calcium in the urinary tract by inhibiting the nidus formation. So that is the preferred choice in presence of renal stone disease, but it is always better to find out the cause and treat that, because we know that many patients are having the primary hyperparathyroidism because of the associated renal stone disease. So we have to rule out and treat accordingly. How to monitor calcium dose? Though the serum calcium not a good parameter to monitor the serum calcium, preferred is urinary calcium excretion. We all know that what is the normal urinary calcium excretion, that is varying from 1 to 4 milligram per kg body weight per day, or you can measure urinary calcium creatine ratio as well. So, in nutshell, I will say that calcium is preferred mode is the dietary source, and the recommended calcium is varies from 800 to 1200 milligram, depends on the stage of the life. Now, coming to the vitamin D, we know that vitamin D is synthesized from the skin, and that may be an important in our mythology that people are preferring or the advice to go and exercise in the sunlight. Though the current recommendation is sunlight is best in the 11 to 2 p.m., but it may be more true for the Western population where the sunlight is not that good in the morning hours. But in India, it is very bright sunlight in the morning, and that is our old tradition. I think it is good to expose yourself in the sunlight, and you can see in this particular diagram that person is doing Surya Namaskar, and that is his body is adequately exposed for the sunlight for the better vitamin D synthesis. So just brief physiology vitamin D. I don't think we need to go in much detail, but that is the vitamin D synthesized in the skin, the Melphalan layer of the skin, and it is under the ultraviolet B, that is 290 to 300 nanometer ultraviolet B rays. The pro D3 in the skin is converted to the pre D3, and that convert into vitamin D3 by isomerization of the pre vitamin D3, and then it enters into the liver where there is first hydroxylation takes place, that is 25 hydroxylation of this vitamin D, and then it enters into the kidney where in the PCD it is again there is one more hydroxylation takes place, that is the 121 hydroxylation, and that is finally formed product is actually 125 dihydroxy vitamin D. And this 25 to 125 conversion takes place in presence of two important stimulator. One is the PTH and second is the low phosphate. These are the good stimulator of the enzyme called 1-alpha hydroxylase, and that will convert it into the 125 hydroxy vitamin D. That is we call it as active vitamin D. So this active vitamin D acts on the intestine, and it improves or the increases the calcium and the phosphate absorption from the bone. It improves the actually in the bone it resorbs the calcium to maintain the serum calcium or mobilize the calcium from the bone. And in this way, this acting this vitamin 125 dihydroxy vitamin D on the intestine and bone, and able to manage the circulatory calcium and the phosphate level. So in India is a sunny country, we know all that. In spite of this bright sunlight, the whatever literature is available from India, the almost every literature from every part of country, all the people those are working in the vitamin D field, whether it is Dr. Goswami, Dr. Mittal, Dr. Marwa, Dr. Tandon, and many more people working throughout the country. But the most of the studies are telling that vitamin D is deficiency is very rampant. Dr. Sushil has a lot of work on the vitamin D as well from the SGPGI. So the vitamin D, in spite of ample amount of sunlight, the vitamin D deficiency is there. What are the reason of this severe vitamin D deficiency in our setting? So these are certain lifestyle things are there. Those are playing an important role in the vitamin D synthesis. And then the latitude is important because over 40 degree of latitude in both winter and summer, the vitamin D synthesis decreases. So some part of the country, our country is above 40 degree latitude, so that is vitamin D synthesis will be less, and that will be deficiency will be there. So what amount of vitamin D is required, or what amount of sunlight exposure is required to synthesize the vitamin D? So that is called one minimal erythemal dose. That is synthesized 40 units of vitamin D, and that is sufficient for at least week time. So the efficient sun exposure is 10 to 15 minutes per day or 2 hours per week on the face and hand. So that should be exposed to the sunlight, not whole body. That is also sufficient, but probably that itself is we are not able to do that because of multiple reasons. And the best time is 11 a.m. to 2 p.m. It is according to the Western guidelines, but recently study by Dr. Marwa et al. They also said that yes, 11 a.m. to 2 p.m. is good time, but maybe something different also. And the criteria to achieve one minimal erythemal dose is that face should become red. That is the clinical criteria. Like in the diabetes, we tell that what is the adequate amount of exercise, meaning by that once you start sweating or you achieve the target heart rate, that is the equivalent to the that day of exercise. So similarly, for the vitamin D synthesis, the face become red. That is the sufficient to synthesize, meaning by that of that particular day vitamin D enough synthesized. Now here I am showing a figure here is that is important, that they say that face and the hands are face and hands are sufficient, but now you can see the mask in this current era of the COVID-19 or the World War C or World War COVID. So your face is again covered with the face mask. There may be vitamin D synthesis even in the less. First, we are not moving out because of this reason, and that's why we are doing this conferences on the virtual meetings in the evening hours rather than the daytime, as well as so that covering of the face will further reduce the vitamin D synthesis. So here that what is the various roles of vitamin D, I think I already explained related to the bone health, and so it may not be. So what is the vitamin D level and what are the definitions of vitamin D? So the deficiency, insufficiency in the normal. So these two columns are there. In one column, vitamin D is expressed in nanogram per ml and the lower panel it is expressed in nanomole per liter. There is a conversion factor, 1 nanogram per ml is 2.5 nanomole per liter. So 10 nanogram per ml meaning by that 25 nanomole per liter. This information is very important for our practitioner colleagues because the various laboratories gives this information in the various forms. And often there is a confusion that the 25 is normal, but if it is a nanomole per liter, it is not normal. So meaning by that, on the basis of that, they divided the vitamin D level in various three important stages. One is deficiency. So vitamin D less than 10 nanogram per ml is called defined as deficiency. From 10 to 30 nanogram per ml is defined as the insufficiency, and or some recommendation is 20 above is you can call it is normal, but definitely more than 30 is considered nanogram per ml is considered normal. So why vitamin D deficiency is so prevalent in our country? One reason can be high melanin pigment in the skin, and we all know that melanin pigment will actually compete with the vitamin D synthesis with the sunlight, and that may be one reason. High level of pollution, though sunlight is there, but pollution might be playing a major role in the major cities where the pollution level is very high, and that will inhibit to reach the ultraviolet rays to the on the land or the on the human surface. And no dietary source of vitamin D. India is I can say significant population is vegetarian, or those are called non-vegetarian. Those are also not taking non-veg diet very frequently, maybe once in a week or something like that. Except Shubhankar Chaudhary sir and that Bengal or the Odisha or maybe some part of the south and southern states may be having a more frequent amount of non-veg diet in form of fish, which contain good amount of vitamin D. But remaining part of the country, those are actually mainly taking vegetarian diet, and I don't recall very good source of vitamin D among the vegetarian diet, except the mushroom. They say the mushroom has a good amount of vitamin D, but we don't eat mushroom that frequent. So the vitamin D is not cannot be taken enough from the diet. Except the some of the places that vitamin D is milk is fortified with vitamin D. Like in Chandigarh, the Verka dairy is there, and their milk is fortified. Half a liter of milk is fortified with the 400 international units of the vitamin D. So milk can be a good source of vitamin D, and there is lot of discussion is going on that vitamin D should be fortified. But the issue is coming that if vitamin D is obtained from the animal source, then you have to put a red dot, and many people may not like to eat or they use that food which is having the red dot. So that is one of the issue coming on that. Then the lifestyle, how lifestyle affects the vitamin D. So you can see here in this picture is that the lady is driving and she is covered almost everything. So if even if she is exposed herself to the sunlight, there is no vitamin D synthesis, very unlikely to vitamin D synthesis. Some of the religious practices, there is hardly any part of body is exposed, so there is very unlikely to synthesis vitamin D, and in addition to that, houses are small, overcrowded, not enough sunlight in houses. Those are also factors can contribute for the low vitamin D level. And those are affluent people. Those are traveling, moving, and those are even moving or traveling in the cars, AC cars. The ultraviolet rays will not enter through these cars, and they will also vitamin D deficient. So vitamin D deficiency is so prevalent, so rampant in spite of the ample of sunlight in our country. So these are the some of the reason. And the COVID pandemic, due to more reasons are no outdoor activity or outdoor activity is there. Even these are the covered one.
Dr. Varada, can you
Yes.
sort of try and summarize and
Okay, sir. Yeah.
bring to close? Yeah.
Yes, sir. So there is vitamin D plays an important role in the calcium absorption also. If the vitamin D is deficient, calcium even you are taking diet may not be enough absorbed. So recommended vitamin D in infants and children is 400, and for the pregnancy 1000 international units. For elderly it is 600 to 800 international units. Though the upper limit is somewhere mentioned is the 4000 international units can be taken. And the treatment of vitamin D, we all know that in doses of 60,000 internationals per week for 8 weeks, then once a month. Injectable choices are also available that can be used. So vitamin D and COVID. So I would say that just that vitamin D supplementation is important COVID-19 further, not only for the bone health, but to prevent themselves from the protect or the prevent less complication related to COVID-19 because of the enough vitamin D is there. And vitamin D supplementation target already mentioned 30 to 80 nanogram per ml, and plan is to achieve target vitamin D level quickly in this period. And some of the issues like vitamin D toxicity I can answer during the discussion part, or use of active vitamin D. One sentence, this active vitamin D or 125 dihydroxy vitamin D known as the vitamin D analog should not be used in the routine practice for the day-to-day management of the bone health. Is indicated for the special situation. And frequency of testing of vitamin D, it is not frequently required, and the supplementation is preferred rather than frequent testing. So thank you very much for the patient listening. If there is any question and comment, I'll be answered during at the end of the session. Thank you, sir.
Thank you, Professor Varnada. That was very important, covering a vast area and especially emphasizing the importance of calcium and vitamin D for bone health. While we associate these more with osteomalacia, the deficiency with osteomalacia, but in the long run, deficiency of calcium and vitamin D also does lead to osteoporosis and, of course, therefore increases the risk of fractures. So I'm sure already I have had several questions coming into the chat box, but we'll come to that later on. We are now waiting for the next talk, which will be sort of more directly related to drugs, what drug to use, when to start, how long to use, what dose, and everything, which will be answered by Professor Sushil Gupta from SGPGI Lucknow, who will take us through the management, the sort of drug treatment in osteoporosis. Over to you, Professor Sushil Gupta.
Thank you. Thank you, Professor Shankar. Really glad to see all of you here and sharing my thought over the treatment of osteoporosis in the current context at the moment. I'm just trying to share my slides.
Yeah, Sanjay sir, you need to unshare your presentation, sir. You have to stop sharing, sir. Yes. Sir.
Just hold on. Can you see the slides?
Yes.
Oh,
Please
that's great.
Start.
So, thanks, Sanjay, for really lucid talk on calcium and vitamin D. In fact, it has made my task pretty easier because I need to talk about any calcium supplements and vitamin D supplements for the course of treatment of osteoporosis. I would be just focusing on osteoporosis medications for osteoporosis. And the major question is when we should use it, which one to use it, and for how long actually. We have a huge list of drugs currently available at the moment. Now, looking at what are the indications of treatment, where to do we really start these medications is basically postmenopausal women with fragility fractures, that is osteoporotic fractures, or postmenopausal women at a high risk of fractures actually, which could be characterized by a bone mineral density as well as by the frac stool. Uh, Subjects who have got T-score less than minus 2.5, either at three sites, either femoral neck, total hip, or lumbar spine, they should be treated. And if you are osteopenic actually, then one has to do the frac stool and do the predicted 10-year probability of hip fracture and major osteoporosis related fractures. The figures which we consider is for hip fractures more than 3 or 3.5%, or for major osteoporosis related fractures more than 10.5%. One thing I really need to emphasize is here that if you got osteoporosis by WHO criteria on the BMD at either at hip, spine, or femoral neck, you need not to do a frac stool. That's one. It is only applicable to osteopenia. And if you got a fragility fracture, there is no need for applying the frac stool because you have got ultimate the golden proof of fragile bones. Now we have got too many drugs available. They can be categorized into two parts: anti-resorptives and anabolics. And we have a huge list in anti-resorptives, which are bisphosphonates, biologics, estrogen and SERMs, and calcitonin. And among anabolics, teriparatide and more recent introduction of abaloparatide and ramusumab are available now. Now, selection of drugs depends on various factors actually. How much efficacious are these drugs in reducing the number of fractures, say around 100 people, if you're treating for a certain period of time, what percentage reduction of the fracture is there? And that we call it anti-fracture efficacy, and that's the most important. We have to look at risk factor for fractures like repeated falls, early age group, and many other factors. We have to look at long-term safety data. We have to look at likelihood of compliance, looking at the cost, various side effects, its availability, and other systemic illness like renal diseases, because we have to look at GFR for starting certain molecules. The most important and most critical one is really and widely used is bisphosphonates actually. Bisphosphonates we all know is inhibits the osteoclast. There is a bone remodeling happening and by the inhibition of osteoclast, the osteoblastic activity overtakes osteoclastic activity, and therefore there is a positive gain in the bone. Bisphosphonates basically binds to the hydroxyapatite crystals. It is ingested by the osteoclast, and these osteoclast undergoes apoptosis, and therefore the osteoclastic activity goes down, and you have got preponderance of osteoblastic activity. There's a long list of drugs available in bisphosphonates group. Available in India. We have got alendronate, risedronate, abandronate, and zoledronic acid. We have got different doses for that. Alendronate is typically given in 70 milligrams per week. Risedronate 35 milligrams per week, though the other MD approved schedules are there, like 150 milligrams per month also. Abandronate is available in both oral as well as IV. Oral it is 150 milligrams per week, and IV it is 3 milligrams every 3 months. And zoledronic acid is currently 5 milligrams per year. Now, what are the kind of reduction of fracture is? All these drugs reduce the vertebral, non-vertebral, and hip fractures. Except abandronate has not been shown to have a great effect on hip fractures. The side effects are almost similar, except very specific things that one has got with bisphosphonates. You have got oral bisphosphonate, you have got esophagitis, musculoskeletal symptoms, osteonecrosis of jaw, and atypical femoral fractures. With abandronate and zoledronic acid, you have got acute phase reaction, and rest of the things are practically the same. So for oral bisphosphonates, it is given in fasting because we are dependent only 1 to 2% of bisphosphonates absorption. Therefore, there is no food or beverages to be given for either 30 minutes for alendronate and risedronate, but 60 minutes for abandronate. And instruction is not to lie down for 30 to 60 minutes after oral dosing to prevent reflux of tablets into the esophagus. These are the most important. Therefore, but oral bisphosphonates are not to be given in a person who's not able to sit down for 30 to 60 minutes after taking the tablet. There are few situations where bisphosphonates are contraindicated, like EGFR less than 35 ml, and esophageal disease like eclasia or hiatus hernia. Now, I shall just go through the certain studies of bisphosphonates in the people. These are pioneer studies published in Lancet, JAMA, and subsequent JCM. And this study shows that this study of alendronate being given for 36 months in the postmenopausal woman with vertebral fractures, one or more vertebral fractures. And it shows a gain in the BMD at the femoral neck by the tune of around 3%, total hip around the tune of 3%, and lumbar spine by the tune of around 7%. And on the right graph, you can see the reduction in the clinical vertebral fractures, hip fractures, and wrist fractures. And all these reduction, the fracture starts happening by almost the curve starts separating by 6 months. And if you look at a proportion of women with any clinical fracture, the graph there is significant reduction in the fractures in the alendronate group as compared to placebo, and the curve starts separating by 6 months, and therefore the medication has to be taken on a continuous basis. Now, there's another study published in JAMA actually, in which alendronate was used in the woman with the low BMD but without vertebral fractures, and it showed almost similar gain in the BMD at the femoral neck, total hip, and lumbar spine with alendronate as compared to the placebo. And cumulative percentage of the woman with any clinical fracture, again the curve starts separating by almost 40 to 16 weeks actually. So therefore, long-term treatment is essential. Now, looking at this vertebral fractures, the first study with the women, it shows a reduction in the vertebral fractures by almost by the tune of around 47%, 47%, and any clinical vertebral fractures by the almost 55%. Now, the most important thing is who are the women who get the maximum beneficial effect. If you really look at the BMD actually, if the T-score of femoral neck BMD is less than 2.5, the reduction in the clinical fractures, the vertebral fractures are the maximum, but it is much lesser in the BMD at the T-score when the BMD is minus 2.5 to minus 2 or minus 2 to 1.6, emphasizing that this drug works best in those subjects who have got T-score less than minus 2.5. Now, this is an extension phase of the alendronate trial. Initially, it was given for 36 months, and thereafter it was extended for 5 years further, which is known as FLAX trial. Is an extension of fracture intervention trial actually. And in this study, the subjects received after the 4 years of alendronate, they received either placebo or alendronate, and it showed that there was a much lesser decline in the alendronate group as compared to the placebo, though they were not receiving the alendronate at that point, showing that there is a residual effect of alendronate which was given in initial 4 years. There was residual effect of alendronate in the bone actually, and it prevented the further vertebral fracture. This was an important study in the sense that it showed for the first time that the residual effect of bisphosphonate is there for many years, and they could be you can stop these bisphosphonates a certain period of time before restarting again. So FLAX trial showed that there is a persistent effect of alendronate on BMD, bone turnover markers, and fracture risk reduction in clinical vertebral fractures even up to 5 years after stopping alendronate. And the anti-fracture efficacy is maintained over a period of 10 years in the subjects who received alendronate for all those 10 years. So we do have a safety data for alendronate for up to 10 years, and we do have safety data on the histomorphometry, and it shows safe. The major complication of long-term treatment of bisphosphonate is basically atypical subtraumatic femoral fracture. This is a classical picture. A sclerotic bone with a spike at one side, on the one lateral side, and it's an oblique fracture, which is classical of bisphosphonates induced atypical subtrochanteric fracture. Another great complication, osteonecrosis of jaw, which is in which the bone is not healing in the after the dental process, and which is a persistent reason to stop when if it is happen or pre-existing in this. For how for how long to continue bisphosphonates? Initially, when you're starting bisphosphonates, alendronate and risolate can be continued for 5 years, as zoledronic acid initially for 3 years. Then one has to reassess either at 3 years or 5 years, depending on the molecule you're using. The subject can be divided into low risk or high risk. Low risk is defined as the subjects who have got a stable BMD or T score minus more than minus 2.5, or some subjects say -2. There is no consensus, but you have got very literature. Currently, we take -2 in our clinical practice. And there is no previous vertebral or hip fracture, either at the baseline or during the course of treatment. High risk is when the person has got history of osteoporotic fracture before or during treatment, and T score or the T score is -3.5. It is high risk, then alendronate or risolate can be continued up to total 10 years, and zoledronic acid should be continued for total 6 years. Now, there's a lot of discussion on drug holiday actually. Is it required? That's the first question. For how long, and how to assess when to restart bisphosphonates? On drug holiday, we don't have any strong consensus, but we know that bisphosphonates accumulate in the bone and has residual beneficial effect even after bisphosphonates. And fracture risk is not significantly increased despite stopping bisphosphonates for a period of around 3 to 5 years. And there is a scare of atypical subtrochanteric femoral fractures on prolonged exposure to the bisphosphonates. What are the factors which determine the holiday? If you have started a bisphosphonate, is a decline in the BMD of more than 5%, lumbar spine BMD, loss of more than 5% on 2 DEXA, 2 years apart on the same DEXA facility, that's the one can restart the bisphosphonates. If their clinical risk factors for fractures, like very elderly age group who have a propensity to recurrent falls, they are more liable to, they can be continued on bisphosphonates. If there's a new osteoporotic fracture or increase of bone turnover markers, especially resorption marker, if there's a rise of the cross lapse over the premenopausal age, then one can restart the bisphosphonates. Of course, there's a lot of controversy about bone turnover markers. There's no current consensus, but we in our practice using CTX to restart the bisphosphonates if it is rising above the premenopausal age. Alternatively, if you don't have all these facilities, one can restart typically after 3 to 5 years of drug holiday. Now, there are many combinations of bisphosphonates with the other drugs, like one can combine bisphosphonate with estrogen or SERMs. It gives small additional benefits in the BMD, but it causes oversuppression of bone turnover and possibly increase skeletal fragility. There's an increased side effect, but we don't have any anti-fracture data regarding this combination. Bisphosphonates can be combined with PTH, but it has got own drawbacks. There's a very little additional benefit in the BMD. In fact, some study shows reduction in the benefit in the BMD, and therefore, as of date, a combination is not advocated. If you have an osteoporotic fracture, should we really continue bisphosphonates or not? There's a lot of controversy, a lot of literature is available, because there is a scare of impaired fracture healing. On one hand, with bisphosphonate, you are suppressing osteoclast, and you want a remodeling and callus formation of the fracture healing. So there could be impaired healing. So in the treatment-naive subjects, one can start bisphosphonates after 2 weeks of fractures or after the of the hip replacement. If already on bisphosphonate and is less than 5 years, then one can continue bisphosphonates and assess possible inefficacy of these bisphosphonates, but because it is important, because there might be some underlying disease which might have not been evaluated at earlier, or there could be further recurrence of some occurrence of some disease process during this course of time. If it is more than, if the person is on bisphosphonate more than 5 years, there is no consensus. Reassess for inefficacy of bisphosphonate, but very empirically, I can say that you can stop for 2 to 3 months time, and then there is no risk of fracture healing. If you got atypical femoral fracture, then one need to stop bisphosphonates because one has to move on to the better drugs like teriparatide. Compliance is a big issue with all these chronic medications, and this is a major detrimental factor for inefficacy of treatment with osteoporosis. It is up to 60% over a period of 36 months, and if there's non-compliance is there's a 20% higher risk of any fracture, lower rate of outpatient utilization, and 13% higher medical cost. And therefore, compliance is very important with all these drugs who have to be taken on a regular basis. Now, moving on to another anti-osteoporotic agent is denosumab, which is a fully human monoclonal antibody to the receptor activator of rank ligand, and which is a factor in the osteoclast differentiating factor. And therefore, denosumab reduces the osteoclastic activity. It is indicated not as an initial treatment for osteoporosis, but it should be used in the subjects who have a high risk of fracture or with pre-existing fracture. If there's an intolerance to bisphosphonates, if the person is very likely to be non-compliant with teriparatide or abaloparatide, and if you've got impaired renal functions. It can be used as adjuncts to the follow-up treatment of teriparatide. It should not be used as an initial therapy because bisphosphonates has got a better safety data, and there are certain drawbacks with denosumab. I shall be coming to that later. Now you have two trials of denosumab. Major two trials is Freedom trial and Freedom extension trial. Freedom trial was for 3 years, in which 60 micrograms subcut is given every 6 months time, and it reduced a fracture risk, new vertebral fracture by 68%, hip fracture by 60%, non-vertebral fracture by 20%. Freedom extension trial showed that there is a gain in the lumbar spine BMD by the 18%, and gain in the total hip BMD was almost 8%. Denosumab has been compared with the other drugs. It has been compared to alendronate in a randomized controlled trial. Denosumab gives you better BMD gain, but there is no fracture data. And alendronate in a population-based study with the alendronate, actually, it shows a similar fracture incidence, so it is pretty comparable. If somebody is taking alendronate and given denosumab versus alendronate continuation, where the gain in the BMD denosumab group is much better as compared to alendronate group. Now, there are a few controversies about denosumab. There is no consensus of optimal use. It is certainly not as an initial therapy in the low risk cases. There is no head-to-head fracture efficacy data with zoledronic acid, teriparatide, but it appears similar, but definitely is better than oral bisphosphonates. For how long we can use denosumab? We do have a safety data for 10 years, which is coming from Freedom extension trial. There is no drug holiday. This is important actually because there's an increased risk of multiple vertebral fracture on sudden stopping. And once you stop, the BMD gain is reversed within 24 months of stopping. So if one is really planning to stop, then the first thing is one has to be compliant. If it's not compliant, then one should move on to bisphosphonates or teriparatide. If low risk by clinical BMD criteria, one can stop and replace with bisphosphonates. So there is no need to stop it, follow it with bisphosphonates. It is well-tolerated drug. There is no evidence of atrial fibrillation or symptom of hypocalcemia, but reports are there. It causes significant pain in the back, extremities, and muscular pain, even many months after the injection. It causes hypercholesteremia, cystitis, and Freedom trial showed that some people have got more incidence of eczema, cellulitis requiring hospitalization, and flatulence, which is pretty unusual actually for this kind of drug. Now, another drug is teriparatide, which we have been using for the last decade. Actually, it is a recombinant PTH134, and it acts through PTH1 receptor. Intravenous PTH treatment gives enhancement of the trabecular thickness, number, and connectivity. Therefore, the fracture risk is much reduced. It has got some effect on the cortices, also increase the periosteal diameter and decrease in the cytokine mineralization. As per FDA, it is to be given for subcutaneous month, 20 micrograms daily as subcutaneous, and there is a long-term safety concerns, and the cost is important factor here. It is indicated in the man or the woman with severe osteoporosis with fragility fracture, with the subjects who have got a high risk of fracture, that is T-score less than minus 3.5 in the absence of fracture, intolerance or contraindication of bisphosphonates, failure of bisphosphonates or other therapy, atypical subtrochanteric femoral fracture with bisphosphonates and glucocorticoid-induced osteoporosis. It's not indicated in certain situations, primary or secondary hyperparathyroidism, hypercalcemia, Paget's disease because there's an increased risk of osteosarcoma, any malignancy, skeletal radiation, and in the children. Dosing schedule is, I said earlier, standard is 20 micrograms per day, suppressed daily for maximum 2 years. There are certain trials of using of it cyclical as well as once weekly. In cyclical, it is a long-term treatment is superimposed with the cyclical PTH 3 months on and 3 months off. We don't have any fracture data about this, and it can be used once weekly, either 60 microgram per dose per week for 48 months. It has been used, giving an increase in the lumbar spine BMD by 6 to 8%, and 56.5 microgram weekly for 72 weeks in one Japanese study, and it reduced new vertebral fractures significantly. Abaloparatide is basically PTHRP analog, PTHRP 134. It binds more selective to RG conformation of PTH1 receptor. It has got more transient response than teriparatide, and it favors the bone formation while minimizing bone resorption and hypercalcemia. There is a similar increase in the BMD as teriparatide, but causes less hypercalcemia. Dose is 80 micrograms daily for maximum 24 months. The combination of PTH with various drugs, PTH combination with bisphosphonate is not recommended. I said earlier, PTH after bisphosphonates, it is recommended if it is intolerant to bisphosphonates. In the bisphosphonate patients, the BMD gain is much better as compared to the subjects who have got already received bisphosphonates. PTH in combination denosumab gives better BMD gain. When both are given, the gain in the BMD at the lumbar spine is 9%, as compared to teriparatide by 6%, and denosumab alone 5.5%, but there is no fracture data. PTH can be given after raloxifene treatment, and PTH can be combined with estrogen. It has got a better BMD gain, but we don't have any fracture data. But the monitoring while on treatment with the teriparatide is required. Serum calcium, there is no consensus. Various reports have shown none to once in 3 months time, but we are not regularly monitoring, except some people recommended at least one should repeat one serum calcium levels after 3 months time. BMD again, because almost 98% of people gain in the BMD have the fracture risk reduction. 2% don't respond. Why they don't respond, we really don't know the answer. The literature is new, and so it is very subjective to the BMD. Typically, it is done after 1 to 2 years of time. What after teriparatide? Once we give the teriparatide, being anabolic, increase the BMD, but once we give the teriparatide after 12 months time, there's a lot of loss of lumbar spine BMD by 2%, and typical volumetric BMD is reduced by 17%. The important thing is fracture risk is not increased over 18 months despite reduction in the bone mineral density. Actually, that's very important. Therefore, to preserve this loss of the bone, one needs to give the anti-resorptives. And primary the anti-resorptives we use is bisphosphonate, either per oral or intravenous. And when we give, if we give alendronate, increase the BMD by 6% in the first year. Raloxifene can be used in the woman only. And denosumab for 24 months increase the lumbar spine BMD by 8.6%, femoral neck BMD by 5.6%, and total hip BMD by 4.7%. And this data comes from data switch study. In contrast, if you give denosumab followed by PTH, it has got less BMD gain. Now, there's a lot of questions we ask. Can we retreat the person with teriparatide? FDA regulation says that it is 24 months in the lifetime. So one should use only for 24 months and not more. But people are there who are using it's an off-label use. It increases the lumbar spine BMD, but the gain is much less than earlier exposure, and we don't have any fracture efficacy or safety data for more than 24 months of use. Similarly, after abaloparatide, the same schedule is there. We can use either any other anti-resorptives, and if you give the bisphosphonates for 24 months, it significantly reduces morphometic vertebral fractures and non-vertebral fractures. Abaloparatide and teriparatide had these kind of side effects: hypercalcemia, hypercalciuria, orthostatic hypotension or tachycardia, nausea, headache, muscle cramps, gout perspiration, osteosarcoma. The major scare of not using abaloparatide and teriparatide is risk of osteosarcoma, but it has been shown to be pretty safe. There's only 3 cases in 1 billion patients treated actually. So it's very, very rare, and all these 3 cases has got some predisposing condition to osteosarcoma like skull radiation. Now, most recent introduction to the armamentarium ramusumab which is an anabolic anti-sclerostin antibody. Sclerostin basically inhibits bone formation or binding to LDL5/6 component of LRP5/6 frizzled co-receptor complex that measures the WNT pathway, and this is currently approved by FDA and Health Canada. It is indicated in the subjects who have got osteoporosis, high risk of fractures. Just a couple of
Professor Gupta, hope we will be winding
just
up soon.
One more
Sure.
slide, sir.
Sure.
It should be advocated in severe osteoporosis with a T-score minus 2.5 plus fracture. If someone has got multiple vertebral fractures and the subjects who have got failed anti-disruptives, dose is 210 micrograms per month subcutaneously for 12 months, followed by an anti-disruptive. Therefore, it is to be given only for 1 year. It should be avoided in subjects who have got myocardial infarction or a stroke. This is a trial in which ramucirumab was given for 1 year and therefore followed by denosumab, and it gave the BMD gain of at lumbar spine 13%, total hit by 7%, and femoral neck by 5%. Once we are using ramucirumab, there's significant reduction in the fracture of new vertebral fractures here, and at 24 months, significant reduction in the denosumab ramucirumab combination group in as compared to this thing. Once we compare the ramucirumab with the teriparatide, ramucirumab gives you better BMD gain than teriparatide, but we don't have any fracture data. So current status, it is more anabolic in BMD as compared to teriparatide, but we don't have any fracture data. So I conclude that there's a wide spectrum of drugs, and we're still having more and more drugs in our armamentarium. Multiple options are available. Often sequential therapy is required. So judicial use is possible. If it is a low risk, then one should use bisphosphonates. High risk, teriparatide, abaloparatide, ramucirumab, or denosumab can be used. Thank you very much for a patient hearing. Thank you.
Thank you, Professor Gupta, and thanks to all our viewers. In fact, we have got almost 1,000 logged in for this evening's program. I'm sure it's because of the content and because of the speakers and the way they have dealt with the subject. So we have a lot of questions to keep you busy, which could go through the rest of the night, but we have to take some of them. So please excuse us if we can not accommodate all of your questions. Maybe we will take some questions for Dr. Vadara and Dr. Gupta, not necessarily in any order. So if we have Professor Gupta, one of the questions that's asked from Dr. Agarwal from Chandigarh is about bisphosphonate and denosumab and EGFRs. Till what EGFR would you be using, and do you need dose adjustments?
Well, if EGFR is less than 35, I would like to avoid the bisphosphonates because it is excreted through kidney actually. Denosumab can be used at any range of creatinine actually. It is a monoclonal antibody and does not have to do anything with the renal excretion. So you can use denosumab with any kind of renal dysfunction.
And you would like to adjust the dose also?
No.
Okay, right. And so we have from Dr. Agarwal again, a very basic issue, something that we did not cover and the talks is about evaluation or diagnosis of osteoporosis. And so is there any clinical or biochemical surrogate marker of osteoporosis? Is there, Professor Gupta?
Yeah. If you had a fragility fracture, this is a clinical marker actually that you have an osteoporosis. If a fragility fracture is there, you have an osteoporosis, you don't require DXA, you have to rule out secondary causes and go ahead with the treatment. That's first issue. In the absence of fragility fracture, the gold standard is currently DXA, and one has to go for WHO classification of bone mineral density in the terms of osteoporosis, osteopenia, and normal BMD. One thing important I need to emphasize to Dr. Agarwal is that 1/3 of the fracture, if you look at a population of 100 fractures actually, the 1/3 of fractures happens in osteoporotic group, 1/3 fractures happen in osteopenic group, and 1/3 fractures normal BMD. BMD is a clinical marker, is a diagnostic marker of osteoporosis. But again, you can have a fragility fracture with a normal BMD because BMD merges calcium hydroxyapatite density into the bone through a simple Doll energy X-ray. Actually, it does not tell us the bone quality. So the gold standard is for regional fracture, but currently DEXA is a gold standard. If it is osteoporotic, less than 2.5 T-score, less than 2.5 at either sides of uh, lumbar spine, total hip, or femoral neck, one need to treat it actually. Osteopenia, one has to take the use of Frax tool. If the 10-year predicted risk is more than 3% of the hip fracture and 10%, or some people say 20%, we currently take 10%, then one should need to treat it because there's a risk of fractures actually.
Right. But he also asked, Dr. Agarwal also asked whether there's a biochemical surrogate for osteoporosis.
Bone turnover had been used, but they are not a marker of fractures actually. If in a combination of, this is more of a research tool at the moment actually. In the combination of high bone turnover, the presence of the low BMD, it predicts more fractures than otherwise. So, but for diagnosis of osteoporosis, bone turnover markers, as on date, is not required.
Right. But that was a clear message. For Dr. Vodada, there are a number of questions, including how would you like to supplement vitamin D in one who is severely deficient? Do you want parenteral preparation, or is oral, or is there difference between the two?
Yeah, this is a very good question, and it is unexpected answer for the viewers because the oral vitamin D supplementation is faster and achieve the rapid rise in the vitamin D as compared to the injectable one. So to achieve the faster level, oral is better. So generally we prescribe 60,000 vitamin cholecalciferol once per week for 8 weeks. So that is a standard. But if you feel the patient is severely deficient and very symptomatic, in that case, there's another way is that you can give once per day for maybe week time. And then you use for once in fortnight, or then once the level is achieved, you can give the once in a month. So you can give daily, you can give the weekly, depends on the symptoms. The very severe symptoms, you can give daily for 7-10 days.
Right. So that was Dr. Ravi Walkmaru from Nagpur. And we have another question that most patients would ask us. Dr. Mahesh Babu asks, how long vitamin D?
Yeah. So how long? Answer is very clear. As we know that most of the people are vitamin D deficient. And as I mentioned in my talk that we don't have good source of vitamin D. We are not adequately exposed to the sunlight. Then in that case, it is lifelong supplementation. Usually, I can say like that. And that is another important thing is vitamin D toxicity by giving oral is very, very unlikely. Very occasional case reports are there that is mentioned that oral vitamin D causing vitamin D toxicity. So need not to worry if you are there taking orally. But the important caution here is that many times we take injectable vitamin D, and it often happens that the patient is feeling good with one single injection. And what happens is take without consulting a doctor, he keeps taking injection every weekly. And finally he'll end up with the hypercalcemia or vitamin D toxicity. So oral vitamin D safe, there is no chances of vitamin D toxicity, and supplementation is once a month, you can say lifelong. But usually people will actually not that nicely adhere to the diet, to the medication also. We can say that it is usually not possible. So once a month is safe actually.
With Dr.
Yes,
Subhankar,
yes.
can I ask one question? If you can emphasize a micelle-based vitamin D versus a conventional vitamin D, Dr. Vatara, can you emphasize that? Because that's a burning question.
So, sir, actually, this is the now these few vitamin D preparations are available. Those are in the liquid form, and they say nano shots are better absorbed. But I think cost versus benefit, you can achieve the same level of vitamin D with the nearly same amount. So I don't think it is going to any significant difference. Actually, you can take conventional one, you can take the nano shots.
There
From
may be
my point
some
of view.
advantage. Yes, Dr. Gupta. Yeah.
Yeah, I think if I refer to Dr. Raman Mawa's study, the subjects achieving more than 20 nanograms was hardly much different, 86% versus 92%. It, it was a better absorb, the more number of people significantly increased, but the numbers were not too wide apart actually. So, and our experience is we are using, I'm using conventional vitamin D and not using nano shots because I don't see any difference. People on long-term vitamin D while undergoing osteoporosis treatment, maintaining their levels more than 30 nanograms per ml, and I haven't found any issue actually, except in this winter time. I have to increase the frequency because sun exposure goes higher, but the penetration of UVB rays are much lower. So in fact, the paper by Amrish Mittal, of which I was a co-author, we need to take once in a month on the summers and twice in a month in winters actually. So those modification little needs to be done. And maintains vitamin D with conventional vitamin D pretty good actually.
Yeah,
Yeah,
conventional is
Dr.
is quite
Gupta.
quite good.
Yeah.
There may be one sort of area when people, because you are recommended to take it with milk or whatever, with fatty food for improving the absorption. So there are many people, as Sanjay was referring to, with lactose intolerance who do not tolerate milk, do not like to take milk. In those individuals, maybe the micellar form of vitamin D will ensure a better absorption. Well, that's possibly more theoretical, but that is one area where maybe I could prefer the micellar.
Actually, one time food, our food contains enough amount of fat actually, and which is a good vehicle for that conventional
Yeah,
vitamin D. So
yeah,
one can take easily after food actually because fat is already
yeah,
there. It shouldn't
yeah,
take on an empty stomach with
yeah.
water. It has to
Yeah,
take on milk in that scenario.
Right.
But if you're taking after food, there's not much of an issue actually.
so you can say it is some advantage, but it is need not to replace with this nano shots. I think that is the
Sure.
answer. You can take injectable if it is really that is a problem. Like we see many patients of celiac disease. They are diagnosed celiac disease and vitamin D deficiency. Obviously, we know that will take to heal the intestine at least 3 to 6 months to normalize. So during that period of time, this absorption may be defective. So you can use injectable one rather than giving oral one.
Right. I do remember maybe when we started sort of treating, becoming conscious about vitamin D deficiency and treating it, my initial prescriptions used also to have an advice regarding sun exposure. But nowadays, I find I do not write that anymore. So, what do the other experts do, both Dr. Gupta and Dr. Sanjay Vadada? Short answers.
So,
Vitamin D
sir,
deficiency is a lifestyle problem actually,
So,
and
you treat by lifestyle, not by supplement.
it supplement needs to be given because they are not getting exposed to the sun actually. As Dr. Sanjay referred to the minimal animal dose or likewise, and of course the Western day says that one whole body exposure with one
Yeah,
animal
but
dose.
what do you do in your practice?
We ask them to have a regular sunlight exposure and supplement vitamin D as add on actually. But again, the people go for repeating their vitamin D. It comes low because they're not exposed to sun. So it has a part of the whole part of whole change of the lifestyle actually. Sun exposure we recommend on a regular basis, at least for 30 to 40 minutes, at least twice or thrice
Right.
in a week.
Okay.
As
Good. Sanjay. Yeah, Sanjay.
sir, I don't usually write sun exposure on the prescription. That is one thing, and
Yeah.
it is more short that if you are taking, it will work. So it is very well
Okay.
known, and it is difficult
Okay.
to guide anyone to have a sun exposure.
Okay. We have got a very interesting question from Dr. JP Das from Bhubaneswar, maybe Professor Gupta, about SGLT2 inhibitors, pioglitazone. He didn't mention pioglitazone. I'm including that. And the real risk of fractures with the use of these anti-diabetic medications. Do you see them
pioglitazone,
as, yeah,
yeah, pioglitazone is known to reduce the BMD every year by 4%, both in man and woman, and there's an increased risk of fractures. In India, when we have got postmenopausal osteoporosis by the tune of 40 to 45% after the age of 50 years, I would definitely avoid pioglitazone in that age group. That's one. As far as SGLT2 inhibitors and fractures are concerned, we did observe in canagliflozin study, but there was no concrete evidence in other studies. Actually, empagliflozin was not observed specifically, but overall data doesn't tell us at the very strongly that we should not use in the people who have got osteoporosis at the current age.
Right. Thanks. That's crisp. We go on to maybe the last two questions, which are one is from Dr. Chitra Selvan from Bangalore. Maybe pure endocrinologists may not be allowed to ask questions here, but still she has put a question. So she's got a 38-year-old premenopausal woman who sustained a Colles fracture, hip Z-score minus 2.8. She has been evaluated for secondary causes of osteoporosis, nothing forthcoming. She's got a family history of osteoporosis. So how would you manage her? Maybe Dr. Gupta?
Tricky question, actually. Premenopausal woman with a fragility fracture and no underlying cause. I need to ask whether she has got no menopause at this time. She doesn't have premature menopause.
No, she doesn't have. I mean,
She doesn't.
No.
One can, because she has a fragility fracture, it means bone quality is poor. One can give bisphosphonate, but there's a huge controversy about it. But look at clinical scenario, one can give bisphosphonate for 3 to 5 years and stop it and really see onwards that bone turnover markers.
I would possibly give her bisphosphonate, but Sanjay, what's your opinion?
So I think first of all, that is important how in depth you evaluated for the secondary cause. That is important.
Yeah.
And often these kind of patients of 38 years, family history, osteogenesis imperfecta.
Yeah, absolutely.
Very important differential diagnosis. Second, celiac disease. Then important differential diagnosis. If it's not done, they should do, even they go up to the IgA level also, serum IgA, because that is important.
Sure.
Now the coming question is that, sir, I think what I'll do here is I'll do the Frax calculator or maybe Garvan calculator to assess the fracture risk. And as I mentioned that because in Indian people, peak BMD is reaching at the 40 years of age. Some of the study in our CUBE study and some of the earlier data from India is telling peak bone mineral density achieving even later. So, and calcium, vitamin D, if the fracture risk is not high, I think we should just wait rather than giving her monitor for at least 1 year. This BMD is going down or not. If it's going down, you can definitely treat it. But I'll say we can wait for 1 year follow-up with that.
Okay, so we have different opinions. But let's see. Yeah, so it has to be individualized. The last, yes.
There's an excellent paper in JBM and actually perimenopausal woman with the fractures actually. Again, there was a huge controversy about it. So
yeah,
we are not on the same pages. I'm not on the same page as Sanjay also. Yeah.
So the last one is Dr. Jyoti Wadhwa from Hyderabad. Of course, this is not strictly osteoporosis or fracture. So the question is, can you correlate, this is to do with rickets. So there's a child with overt rachitic features. Vitamin D is 15 nanogram per milliliter. So would you ascribe this to vitamin D deficiency or do you need to look for other causes? Sanjay?
Yeah, obviously, sir, if the vitamin D 15 nanogram per ml is, you can say it is insufficiency. So what I'll do is I'll prescribe vitamin D, normalize the vitamin D, and I look for the serum phosphate after normalizing the vitamin D. And often it happens that patient is having the hypophosphatic rickets, and because vitamin D deficiency will also have a low phosphate, and this hypophosphate also have the low phosphate. So once they normalize the vitamin D and looking at the calcium profile, if it is normalized, then it is because of the vitamin D deficiency. It is not normalizing, meaning by that we have to probably find out some other cause for the rickets.
So the understanding to the question is, so are you expecting that the rachitic features will improve after vitamin D?
Yeah, yes, there is a possibility. There is a possibility. Of course, we can say in that case, we have to probably look at what is the PTH level, what is the phosphate level. All these things also suggest us the PTH is high, meaning by that for that particular person, this vitamin D of 15 nanogram per ml is not sufficient to take care of our PTH.
Right. So good. So thank you. So we have even many more questions awaited, but I think it's getting quite late, and we were supposed to stop at 1 hour. We've gone up to 1.5 hours. That's only because the topic is interesting, the speakers made it so interesting, and of course because all the participants took the interest and asked all the right sort of questions. So I think we can sort of wind up with the knowledge that bone health is very important part of our overall health, which is neglected significantly, especially in our country. And it starts with building our bones strong with adequate calcium, adequate vitamin D. And as we understood, in many cases, we would need to have supplements provided, not just from the diet, but as far as possible, it would be recommended, at least for calcium, to get it from the diet. And then, of course, if you have a fracture, even if you do not have a fracture, if you have severely compromised bone health in terms of significant osteoporosis, then there is the role of medications to prevent fractures. And we have had the experts, Professor Sanjay Vadada and Professor Sushil Gupta, taking us through these important aspects. I'm sure it will help us in our daily practice. Thank you once again, especially to our two speakers for the wonderful job they have done, and also, of course, to the 1,000+ attendees for this program. Thank you very much. Over now to the hosts for the final word, and then before we turn in for the night.
Thank you, sir. Thank you.
Thank you, Shubhankar. Thank you very much for coordinating so nicely. Thank you.
Thank you.
Thank you, sir.
Anyone from the organizers? Yeah.
Yeah. Thank you very much, sir, for giving us valuable insight with regard to bone health. I am definitely sure that participant has enjoyed and they have learned a lot with regards to bone health in their day-to-day practice. So I now request Mr. Amit Arora to give vote of thanks, sir. Amit, sir.
Yeah. Good evening to all of you. On behalf of Intas Pharmaceuticals Limited, I must thank all the participants. Now we have 1,000+ participants today attending this web CME. I must thank our faculty, Professor Shubhankar Chaudhary, for guiding us through this program. And we are going to have many more interesting programs on third Sunday of every month. So this is what we are going to be doing. And Professor Chaudhary has agreed and he has consented to be part of this program as course director. And he is going to give us a lot of interesting topics. We are going to get you the best of the faculty for this program, and I'm sure you will have better learning as far as endocrinology is concerned. I must thank Professor Sushil Gupta for his wonderful talk today, and his agreement to deliver this talk today. I thank Professor Sanjay Vadada for his wonderful lecture, and I must thank all the support team who has helped us organize this web CME. So thank you one and all, and hope to see you next third Sunday in the month of July. For that, we will give you the complete program well in advance.
Saturday.
So, yeah. Third Saturday. Sorry. Third Saturday. So thank you very much once again, and we call it a day. And good night to all of you. Thank you.
Good night. Thank you.
Thank you.
Good night.